Welcome, everyone, to the Eligible Clinician Electronic Clinical Quality Measures Education and Outreach webinar series. My name is Michael Karachki with Mathematica. We'll review a few procedural items prior to moving on to today's webinar content. As indicated on this slide, we kindly request that attendees submit questions via the Q&A function, which is located at the bottom of your screen. Please note that both the chat and audio functions are disabled for all audience participants. While attendees will not be able to submit via the chat function, panelists will include links if necessary via the chat. Questions submitted via the Q&A function will either be answered in written form within the Q&A function itself or answered at the end of today's presentation during the live Q&A session. At this time, I would like to turn the presentation over to the Eligible Clinician eCQM CMS lead, Joel Andrus. Over to you, Joel.
Thank you, Mike. Good afternoon, ladies and gentlemen. My name is Joel Andrus. This presentation represents the third and final webinar in our Eligible Clinician Electronic Clinical Quality Measures Education and Outreach webinar series, focusing on performance period 2022's eCQMs. Each year, CMS updates eCQM specifications with clinical, technical, and coding updates, and publishes measures to the eCQI Resource Center. CMS is presenting a series of webinars to broaden eCQM education and outreach, engage stakeholders, and promote the use of published resources. The first webinar, held on April 14th, introduced eligible clinician eCQMs and how to locate and use eligible clinician eCQM specifications, tools, and resources. The second webinar, held on April 21st, introduced the new eligible clinician eCQM, the CMS 646 version 2, intravesical bacillus calmette-guerin for non-muscle invasive bladder cancer, and went into more detail about changes made to two eCQMs in performance period 2022, CMS 347 version 5 statin therapy for the prevention and treatment of cardiovascular disease, and CMS 2 version 11, preventive care and screening for depression, and follow-up plan. The presentation slides for all three webinars, including today's, are located in the eCQI Resource Center at eCQI.healthit.gov. Note, we've included a link in the webinar slides in the chat. In addition, all three webinar recordings will be posted to the eCQI Resource Center. An announcement will be disseminated when available. Back to you, Mike.
Great. Thanks, Joel. All right, so turning to today's presentation overview, we plan to review how to submit questions regarding eligible clinician eCQM specifications via the ONC JIRA eCQM issue tracker. We also will review three high-use measures, and by high use, this means those measures that are widely reported on and or generate the most JIRA tickets. So this includes CMS 165 version 10, controlling high blood pressure, CMS 122 version 10, diabetes hemoglobin A1C, HbA1c poor control greater than 9%, and CMS 130 version 10, colorectal cancer screening. So CMS receives public-facing questions about eCQMs through the Clinical Quality Measure Project Tracking System, CQM tracking system, which is housed within the ONC JIRA project tracking system. JIRA serves as a collaborative platform for logging, tracking, and discussing issues related to eCQMs. Questions specific to eligible clinician eCQM specifications are managed through the eCQM issue tracker. CMS uses stakeholder input primarily to inform future eCQM updates. eCQM stakeholders, such as vendors and implementers, may submit questions that include one or more of the following eCQM categories. So, header, questions on logic, measure intent clarification, value set, educational/informational questions, as well as questions on test cases. So for new users, an account must be created via the ONC Project Tracking System website. The Create an Account link included here navigates the user to a sign-up screen where users are required to enter information such as email, a full name, as well as create a username and password. And the goal of the eCQM issue tracker is to respond to eCQM stakeholder inquiries in an accurate and timely manner within 10 business days where possible. Additionally, CMS uses the eCQM stakeholder to inform future measure updates, as well as evaluation of trends and reoccurring themes in ticket submissions over time. Okay, we will now review the fields that users will be asked to complete upon submitting questions via the ONC JIRA eCQM issue tracker. So upon logging in to ONC JIRA, users will navigate to the eCQM issue tracker. And this is accomplished by first selecting projects in the top ribbon. Here we see in blue. A drop-down list of projects will appear. So for users who are new, you may not see eCQM issue tracker listed here. So you would need to select view all projects, which is an option that you'll see. This image is just cut for purposes of the presentation. So you'll locate and select the eCQM issue tracker CQM project. Okay, the next step entails creating and documenting your inquiry, right? This is the important part. So to accomplish this, first, you'll select the blue Create button that's circled here, located in the top ribbon, which will prompt the Create Issue screen. So on the Create Issue screen, you will select issue type eCQMs from the pull-down list, as we see here. The next, submitter should complete the following fields. So beginning up top here, we have the summary field in which you'll fill in a brief description of what issue needs to be addressed. Next, for impact, we're looking for you to include information describing in what way the noted issue is affecting you and your organization. Then for the description, essentially what we're looking for is you to elaborate further or expand on the issue that you've noted. So this could include providing relevant logic statements, if applicable, or test case scenarios, or any other details that will assist in responding to your inquiry. And I think it's also important to note that while we're looking for detail in the description field, and we certainly appreciate that, it's also important to attempt to try to sort of keep the information as concise and focused on your particular issue as possible. So this will allow for a JIRA issue response team to get you a response quicker, as well as more accurate to the specific question you've noted. So as an example, let's say a submitter wants to know if 3 specific CPT codes will be added to CMS2 to support clinician workflows. So they may fill out all the issue response fields as follows. So again, going from the top, for summary, again, all of this is hypothetical, but please consider adding new CPT codes to CMS2, preventive care and screening for depression follow-up plan. Impact, so maybe the impact is it supports clinician workflows. And for description, please consider adding CPT codes, and we could specify those, right? 99441, 99442, 99443 to value set encounter to screen for depression. And also I'd ask, it'd be great to include the OID as well, a specific OID for the value set. We could say used with data type and counter performed in the measure, as these data elements are used to support clinician workflow for this measure. So submitters then identify the affected eligible clinician eCQM or eCQMs, depending on your ticket. So we're kind of looking at the center here. So fields for both the current performance period, so right now 2022 performance period, as well as the two prior performance periods, so 2020, 2021, are included. Again, this is just a snippet here, but in the actual view, you'll see multiple performance periods. So note, for each performance period, there's a drop-down list of eCQMs for both eligible clinician and eligible hospital measures. So therefore, it's important that you ensure you are searching for your affected measures in the eligible clinician fields. And if you can't find your measure, that most likely is the reason why you'll be looking in eligible hospital. So for a given issue, it is important that submitters identify and select the correct performance period, as well as all impacted measures. So that may seem a little redundant. However, in many cases, an inquiry will relate to an eCQM or eCQM from two performance periods, right? So let's use, again, CMS2 as an example. You may be looking at an update that was applied to the 2022 version or version 11, but your baseline maybe is the version 10 or the 2021 version. So if this is the case, and you would then select both versions of the measure. Similarly, if you have more than one affected eCQM, then obviously you'd list both of those as well, and multiple performance periods if applicable. Now, how do you select more than one eCQM? So you may accomplish this. What you do is you'd first hold the control key on your keyboard, while at the same time, while you've got that control key held, select all applicable eCQMs relevant to the issue. And then you can just let off the control key and it'll stick. Similarly, you can remove eCQMs that you've designated by holding the control key and remove one or more. Okay, so then next, attachments. You may upload any relevant documentation via either drag and drop or by browsing for the relevant file. So we request that you do not upload any protected health information or PHI. That's important. Next, what's not shown here is you will enter your contact information. So again, this includes a name, email, phone, and institution name. And then finally, you will see a blue create button in the bottom right of the screen, which you will then select, which will then create your inquiry. Submit your inquiry, I should say. Okay, this slide includes several tips for users submitting questions about eCQMs. Now, these tips are important as they allow the JIRA issue response team to provide both a timely and accurate response. As we go through them, we'll kind of see how this may impact the time it may take for you to receive a resolution and effectively research your issue. So number one, use clear and concise language where possible. Including completing sentences when documenting issues. The second tip cannot be stressed enough. Ensure you identify the correct eCQM number and corresponding version of the eCQM or eCQMs you're referencing in your inquiry. This goes for identifying eCQMs in the list on the create issue screen we've just looked at, but also, just as important, including the correct eCQM and version number within the text fields themselves. So, really I'm looking at description, but also the summary and impact if applicable. So for instance, if, we're looking at 2022 version of the CMS 347, it's important to include CMS 347 version 5. And if you are going back to a previous version to, okay, version 4, 347 version 4 states, XYZ, and version 5 ABC, this kind of thing. So this is especially important if your inquiry references more than one version of the eCQM. So if an eCQM and or corresponding version is not identified, what will happen generally is the JIRA issue response team will need to follow up with you to discern this information. And of course, that'll then delay the response. Okay, so next, if an issue corresponds to specific logic statements in CQL logic and the specification, it is important and very helpful to document the logic. So whether that means taking screenshots and uploading as an attachment, or however you wish to document. And note that you may include several screenshots in a single attachment if necessary. So sometimes just for organizational sake, it may be easy just to, I don't know, put them in a Word document or Paint or whatever the case may be, just to have it in one location. Alternatively, you can upload several, but as organized as possible will help your JIRA issue response team reply. So, and if your inquiry corresponds to a value set or value sets, please specify the OID as well as the individual codes you may have questions about. That's also extremely helpful to get to the root of the issue that you may be having. Also goes for specific QDM data types when specifying data elements. One final note here. So it's really important that you try to avoid, where possible, including text in the solution field. It just kind of muddies the waters, and this field is dedicated to inputting the response posted by the JIRA issue response team. Okay, monitoring eCQMs. So as we've noted a few times here, eCQM stakeholder input is used by CMS to inform future measure updates, as well as CMS will evaluate trends over time, and that's used to sort of conduct process improvement and analyses. So just a few examples of ticket trends that we've seen over time. So for instance, we're looking at the eCQMs that consistently receive the most JIRA inquiries across performance periods. And we do note that there's a rise in JIRA ticket volume in June, July, and August. And this is something we've seen year after year, and it corresponds to the release of the May publication, the new measures. So we anticipate seeing an uptick in JIRA inquiries following the May 6th publication of performance period 2023 eCQMs. So with that, I'd like to turn the presentation over to Noel, who will review a subset of those high-use eCQMs. Noel, over to you.
Thanks, Michael. For the next part of the presentation, we will review 3 high-use eCQMs for performance period 2022. We will review each of these measures and review several topics pertaining to each eCQM that we frequently receive questions about. Let's begin with CMS 165 version 10, controlling high blood pressure for performance period 2022. This measure is a proportion measure that evaluates the percentage of patients 18 to 85 years of age who had a diagnosis of essential hypertension starting before and continuing into or starting during the first 6 months of the measurement period, and whose most recent blood pressure was adequately controlled during the measurement period. It is an intermediate outcome measure, and a higher score indicates better quality of care. So at a high level, the clinical recommendation for CMS 165 recommends screening for high blood pressure in adults age 18 years and older, which is based on the U.S. Preventative Services Task Force guidelines. It's also recommended that the target blood pressure of less than 130/80 for adults with confirmed hypertension and known CVD or 10-year ASCVD event risk of 10% or higher, and a target blood pressure of less than 130/80 is reasonable for adults with confirmed hypertension without additional markers of increased CVD risk. The complete clinical recommendation statement provided in the measure header includes further recommendations for adults with confirmed hypertension, initiation and intensification of pharmacologic treatment, and patients with diabetes and hypertension. The complete clinical recommendation statement for CMS 165 is available at the eCQI Resource Center website. And this slide displays the guidance for CMS 165. The guidance text aims to help clarify which type of blood pressure readings are acceptable or not acceptable, when blood pressure readings should not be included, and how to address multiple blood pressure readings on the same day. This section also identifies the measure, or if the measure is a patient-based or episode-based measure. This measure is a patient-based measure which evaluates the care of a patient and assigns the patient to the appropriate populations. Also, the guidance section clarifies which version of the eCQM quality data model or QDM standard is used. Let's take a look at the population criteria for CMS 165. The initial population includes patients 18 to 85 years of age who had a visit and diagnosis of essential hypertension starting before and continuing into, or starting during the first 6 months of the measurement period. And the denominator equals the initial population for this measure. There are multiple denominator exclusions for CMS 165 as seen on this slide. At a high level, the denominator exclusions include patients with evidence of end-stage renal disease or ESRD, dialysis or renal transplant before or during the measurement period, and patients with a diagnosis of pregnancy during the measurement period, as well as patients who are in hospice care, patients 66 and older who are living long-term in an institution for more than 90 consecutive days, certain patients with an indication for frailty, and patients receiving palliative care. If a denominator exclusion is met, it would remove the patient from the measure population and denominator before determining if the numerator criteria are met. The numerator consists of patients whose most recent blood pressure is adequately controlled, which is a systolic blood pressure of less than 140 and a diastolic blood pressure less than 90 during the measurement period. And there are no numerator exclusions or denominator exceptions for CMS 165. Next, let's review just a few key pieces of logic for CMS 165, beginning with the initial population. As we discussed on a previous slide, patients 18 to 85 with a diagnosis of essential hypertension are included in the initial population. The parameter for using the patient's birth date, the function called calendar age in years at, is used to calculate the patient's age at the start of the measurement period. For this initial population, the patient needs to be 18 to 84 on January 1st, 2022 to meet this criteria. The intent of the measure is to capture patients who turn 85 by the end of the measurement period by including patients who are 84 at the start of the measurement period. If we look at the age intervals used in the measure logic, we see 18 is included in this part of the logic through the use of a closed or square bracket, and 85 is not included through the use of a curved bracket. The logic also includes the adult outpatient encounters library, and qualifying encounters include office visits, preventative office visits, preventive services, or home health services that are provided during the measurement period. Also, both online assessments and telephone visits definitions use the encounter performed data type, and if a code is present from either the online assessments or telephone visits value sets, it will meet this logic. As we discussed earlier, the measure contains multiple denominator exclusions. The logic for the denominator exclusions includes all of the conditions that would meet these criteria. So, I had mentioned earlier, patients with evidence of end-stage renal disease, dialysis or renal transplant before or during the measurement period, and patients with diagnosis of pregnancy during the measurement period meet these criteria. These criteria are referenced in this logic in a way that the "or exist" here links each of these definitions so that only one criteria needs to be true to exclude the patient from the measure. The new value set related to palliative care is also used across multiple measures, and we've received questions asking if orders or diagnosis are acceptable. Currently, intervention performed, assessment performed, and encounter performed is required by the logic to meet that denominator exclusion. So orders or diagnosis would not be acceptable. Numerator logic reflects patients that meet the initial population and denominator who also have adequately controlled blood pressure during the measurement period. Numerator evaluates for the lowest blood pressure reading on the most recent day. The next logic statements are used to retrieve the most recent qualifying blood pressure. The most recent blood pressure day logic uses the relevant date time and relevant period timing attributes. The relevant date time is a single point in time, and the relevant period defines the start and end of the most recent blood pressure day. And we are using the global latest of to identify the most recent reading. If the most recent qualifying blood pressure is a diastolic less than 90 and a systolic blood pressure of less than 140, the numerator will be met. And we frequently find trends with submitted JIRA tickets related to visit types for acceptable blood pressure readings, as well as telehealth services. Users frequently submit questions about multiple blood pressures on the same day and which blood pressure to use as the most recent blood pressure reading. In cases with multiple blood pressure readings on the same day, you would use the lowest systolic and lowest diastolic reading as the most recent blood pressure reading for the measure. This guidance is intended to provide direction during data collection for measure users when multiple readings are found on the day that represents the date of the most recent blood pressure reading. It is not intended to be guidance for providers for how to collect blood pressure readings. This guidance was added to the eCQM to reduce confusion about which blood pressure reading to use when multiple readings are on the same day. Also, we frequently receive questions related to the validity or accuracy of using a single blood pressure reading for the measure. The measure is based on the HEDIS health plan measure, which evaluates the most recent blood pressure reading in the patient's record. The focus on the most recent reading is meant to minimize data collection burden and provide clear direction for measure users. It's also important to understand that the measure does not require the blood pressure readings to be taken during or to be directly associated with one of the qualifying encounters used to identify the initial population and denominator. While the patient must have a qualifying encounter during the measurement period, the measure looks for the most recent or latest blood pressure readings documenting the patient's medical record during the measurement period that are not during an inpatient encounter or an ED visit. The measure is not looking for a specific type of visit or encounter during which the most recent blood pressure was taken. And for telehealth eligibility, patient self-reporting, questions are frequently asked if the clinician must see or visualize the blood pressure during the telehealth encounter, or if the patient can self-report the blood pressure result. For the blood pressure reading to count toward the numerator, the clinician must read the information from a valid remote monitoring device during the telehealth encounter. The remote monitoring device must be an electronic device that is capable of digitally storing and transferring readings to the provider. In order to be a valid remote reading, the blood pressure reading can be transmitted directly to the EHR or read by the clinician. Therefore, it is not acceptable for patients to self-report the blood pressure reading. Finally, this slide shows some of the codes and value sets included in CMS 165. The direct reference codes, or DRCs, included at the top of this section are individual terminology codes specified in the measure logic to describe the clinical concept when just a single code is needed for representation. The value sets are a specific set of codes and their descriptions that define a clinical concept, and they are drawn from one or more code systems, such as CPT, ICD-10, SNOMED CT, and BLOINC. The terminology section includes the codes and value sets used in the measure, and you can find and download the complete list of codes and value sets at the Value Set Authority Center, or VSAC, website. Okay. Next, we're going to review CMS 122 version 10. It's the diabetes hemoglobin A1C poor control with a greater than 9%, or which is greater than 9%. This measure is a proportion measure that is stewarded by the National Committee for Quality Assurance and identifies the percentage of patients 18 to 75 years of age with diabetes who had a hemoglobin A1C greater than 9 during the measurement period. It is also an intermediate outcome measure, and a lower score indicates better quality care. The clinical recommendations for CMS 122 are based on the 2020 American Diabetes Association guidelines, and at a high level, recommends A1C goals based on non-pregnant adult patients, provider judgment, and patient preference. And this slide displays the guidance for CMS 122. Some key items to mention here are if the hemoglobin A1C test result is in the medical record, the test result can be used to determine numerator compliance. Only patients with a diagnosis of type 1 or type 2 diabetes should be included in the denominator. Patients with a diagnosis of secondary diabetes due to another condition should not be included. Similar to the previous measure discussed, this measure is patient-based, meaning it evaluates the care of a patient and captures a count of patients in the appropriate populations. Next, let's take a look at the population criteria for CMS 122. The initial population includes patients 18 to 75 years of age with with diabetes with a visit during the measurement period, and the denominator equals the initial population. This slide contains the denominator exclusions for CMS 122. Like we saw with CMS 165, some of the same exclusions apply to this measure, like patients who are in hospice care, patients 66 and older who are living long-term in an institution for more than 90 consecutive days, patients with an indication for frailty, and patients receiving palliative care. Again, the denominator exclusions will remove a case from the measure population and denominator before determining if the numerator criteria are met. In patients whose most recent hemoglobin A1C level performed during the measurement period is greater than 9% or is missing or was not performed during the measurement period, meet the numerator. And there are no numerator exclusions or denominator exceptions for CMS 122. Next, we'll review just a few key pieces of logic for CMS 122, starting with the logic pertaining to the initial population. The initial population logic includes patients 18 to 75 with a diagnosis of diabetes and a visit during the measurement period. The initial population logic includes and exist, which requires the patient's age, qualifying encounter, and diabetes diagnosis to meet the initial population. Like we saw with CMS 165, a parameter is used for the patient's birth date. A function called calendar age in years at is used to calculate the patient's age at the start of the measurement period. For this initial population, the patient needs to be ages 18 to 74 on January 1st, 2022 to meet this criteria. The intent of this measure is to capture patients who turn 75 by the end of the measurement period by including patients who are 74 at the start of the measurement period. If we look at the age intervals used in this measure, we see that 18 is also included in this part of the logic through the use of a closed or square bracket, and 75 is not included by the use of a curved bracket. The next parameter includes adult outpatient encounters library and the qualifying encounters, which include office visits, preventative services, and home health services provided during the measurement period. Also, the telehealth services definition uses the encounter performed data type and references the telephone visits value set, which will satisfy the condition if a code is present from that value set. The diagnosis data type references the diabetes value set, and the timing for diagnosis uses the attribute of prevalence period, which references the onset and abatement times for the diagnosis. In this case, the prevalence period for the diabetes diagnosis needs to cross over the measurement period. For example, diabetes could have started 10 years ago, but as long as there is no end date, it's still an active diagnosis. And as we discussed earlier, the measure contains multiple denominator exclusions, all of which we saw in CMS 165, like hospice, frailty, long-term care, and palliative care. The logic for the denominator exclusions includes all of the conditions that should be removed from the denominator before determining if the numerator criteria are met. Like we previously discussed, the or exists here in this logic also links each of these definitions in a way that if one of them is true, the patient is excluded. The numerator logic may be met by having the most recent elevated hemoglobin A1C with a result greater than 9%, by the most recent hemoglobin A1C without a result, or by no record of a hemoglobin A1C. Further definitions are necessary to meet the numerator as well. At a high level, the first two definitions under the numerator require the most recent hemoglobin A1C, which uses the relevant date time and relevant period timing attributes. And we're using the global latest up here to identify the most recent results. The last definition on this slide uses the laboratory test performed data type and hemoglobin A1C laboratory test value set, along with the relevant date time and relevant period timing attributes and the latest up function from the Global Common Library to identify the most recent hemoglobin A1C lab test during the measurement period. There are several trends that we see in JIRA tickets related to the numerator for CMS 122. We've received various questions related to how hemoglobin A1C results are documented in the EHR, which values should be used, and whether there are minimum and maximum values. To clarify, the measure uses LOINC codes to look at the hemoglobin A1C tests, which do not specify minimum or maximum value. You can find this information in the hemoglobin A1C laboratory test value set. The measure logic looks for the hemoglobin A1C test result greater than 9% in the has most recent elevated hemoglobin A1C greater than 9% definition. If the most recent hemoglobin A1C is less than 9%, the case does not qualify for the numerator. And if the most recent hemoglobin A1C is greater than 9%, the case would meet the numerator. Also regarding which hemoglobin A1C results are acceptable, a patient-reported test can be acceptable provided that the result is sent to the lab or provider's office for analysis. The data must be entered into the EHR and documented, and the documented result must use a LOINC code found in the hemoglobin A1C laboratory test value set. The required documentation is a laboratory test performed, the result from the test, and the date of the test. We've also received questions regarding continuous glucose monitors. The measure currently does not allow for the use of values from continuous glucose monitors. Rather, the measure solely relies on hemoglobin A1C values obtained from lab tests. Also, there have been questions related to overlaps in the measurement period, specifically when the start date time is null and the end date time is after the measurement period. The logic does consider periods with missing start or end date times, and therefore both are acceptable per the current specification. If the beginning or end of an interval is null inclusive, calculations should be used, or calculations should use the minimum or maximum for the data type. For example, if the start date time or start date was null and the end date was 3/4 of 2022, this would meet the overlaps criteria of 1/1/2021 to 12/31 of 2021. And finally, these are the direct reference codes and value sets used in CMS 122, which can be found in the terminology section of the eCQM. You can, again, find and download these or the complete list of codes and value sets at the Value Set Authority Center website. And next, we're going to review CMS 130 version 10, colorectal screening or colorectal cancer screening. This measure is a proportion measure that is stewarded by the National Committee for Quality Assurance and identifies the percentage of patients, of adults aged 50 to 75 years of age who had appropriate screening for colorectal cancer. It is a process measure, and a higher score indicates better quality care. At a high level, the clinical recommendation for CMS 130 recommends screening for colorectal cancer starting at age 50 and continuing until age 75. Acceptable screenings include a colonoscopy, flexible sigmoidoscopy, fecal occult blood test, fecal immunochemical or test or FIT DNA, and CT colonography. And this slide displays the guidance for CMS 130. Some key items to mention here are do not count digital rectal exams or DREs, a fecal occult blood test performed in an office setting or performed on a sample collected via DRE. Like the previous measures that we discussed, this measure is also patient-based. The initial population for CMS 130 includes patients 50 to 75 years of age with a visit during the measurement period, and the denominator equals the initial population. And this slide contains the denominator exclusions for CMS 130, which includes patients who are in hospice care for any part of the measurement period, patients with a diagnosis or past history of total colectomy or colorectal cancer. Again, the denominator exclusions will remove a case from the measure population and denominator before determining if the numerator criteria are met. At a high level, patients with one or more screenings for colorectal cancer meet the numerator. CMS 130 does not have any numerator exclusions or denominator exceptions. Next, let's review just a few key pieces of logic for CMS 130, and we'll start with the initial population. As we discussed earlier, the initial population includes patients 50 to 75 years of age with a visit during the measurement period. Again, the inclusion of "and exist" in the initial population logic reflects that both the age between 50 to 75 and a qualifying encounter must both be true to meet the initial population. This logic also begins with the parameter for using the patient's birth date, similar to the previous two measures we discussed. The function calendar age in years at is also used in this measure to calculate the patient's age at the start of the measurement period. For this initial population, the patient needs to be ages 50 to 74 on January 1st, 2022. The intent of this measure is to capture patients who turn 75 by the end of the measurement period by including patients who are 74 at the start of the measurement period. Like I mentioned on the previous measures, if we look at the age intervals for this measure, we see that 50 is included at this part of the logic through the use of a closed or square bracket, and 75 is not included through the use of a curved bracket. Also, this logic also includes the adult outpatient encounters library, and qualifying encounters include office visits, preventative services, or home health services provided during the measurement period. Also, both online assessments and telephone visit definitions are used, they use the encounter performed data type. So again, if a code is present from either of those value sets, it will satisfy this condition. And as we discussed earlier, the measure contains multiple denominator exclusions. The or exists here also links each definition in a way that if one of them is true, the patient is excluded. Patients who are in hospice care, patients with that diagnosis or past history of total colectomy or colorectal cancer, patients with an indication for frailty, and patients in long-term care or palliative care meet these exclusions. We've seen a couple of trends in questions submitted regarding the denominator exclusions with relation to value sets, specifically the acceptability of codes that are not included in a particular value set. Generally, users are asking if a code not included in a value set can be acceptable. However, if the code is not included in the value set used in the measure, the code would not be acceptable for the measure. Again, you can find and download the value sets at the Value Set Authority Center website. You can also recommend codes for inclusion in a value set by submitting a JIRA ticket if you're using a specific code or codes in the field that are not included in the value set. Also, we've received questions asking about exclusions or exceptions for patients that refuse colorectal cancer screenings. However, CMS 130 does not provide an exclusion or exception for patient, medical, or system reasons, and that includes patient refusal. Patients meeting the initial population and denominator who do not have a documented screening would not meet the numerator. And the numerator may be met by one of these procedures or tests provided in this logic. You will notice the numerator logic includes or exists, which reflects that any one of these procedures or tests is acceptable for meeting the numerator. Also, the logic for each procedure or test used to meet the numerator includes the timing specific to each definition. For the colonoscopy performed definition, the timing uses the relevant date time and relevant period timing attributes, similar to what we previously discussed. However, in this logic, we are normalizing that timing in order to compare it to the measurement period. Normalized interval function from the Global Common Library is used to say that if you have a single point in time, use that to create an interval. So the single point in time becomes both the start and end time. Or if you have a relevant period that already includes the start and end time, use that. This enables you to compare the timing of the colonoscopy to determine if it was within 10 years or less on or before the end of the measurement period. The fecal occult blood test performed definition uses the laboratory test performed data type and fecal occult blood test value set along with the relevant date time and relevant period timing attributes. It also uses the latest step function from the Global Common Library to identify the most recent fecal occult blood test during the measurement period. And this slide displays the remaining logic statements that are available to meet the numerator. Also note that each statement contains the timing specific to the procedure or test performed. For the flexible sigmoidoscopy performed definition, the timing uses the relevant date time and relevant period timing attributes, and we are normalizing that timing in order to determine if the flexible sigmoidoscopy was within 5 years or less before the end of the measurement period. For the fecal immunochemical test DNA performed definition, the laboratory test performed data type and fit DNA value set are used along with the relevant date time and relevant period timing attributes and the latest of function from the Global Common Library to identify the most recent test within 3 years or less before the end of the measurement period. And then finally, the CT colonography performed definition uses the diagnostic study, data type, and CT colonography value set with the relevant date time and relevant period timing attributes. And we are also normalizing that timing in order to determine if the CT was within 5 years or less before the end of the measurement period. And finally, this slide shows some of the direct reference codes and value sets included in CMS 130. Again, you can find the complete list of codes and value sets at the Value Set Authority Center website. And this slide references the standards and implementation guides used to support eCQMs, including CQL, HQMF, CQL, HQMF, QDM, and QRDA. Also, there will be additional resources included on slides 42 and 43 of this presentation. And with that, Mike, I will turn it back over to you.
Great, thank you, Noel. And yeah, thanks for all the submitted questions today. Have a few additional questions that we'd like to put forth here. So looks like specific to CMS 122 version 10, would telehealth visits be applicable to meet the initial population?
Why, yes, Mike. Patients with a telehealth eligible encounter during the measurement period can meet the initial population for CMS 122 as long as they meet the other denominator age and diagnosis criteria.
Okay. Moving along, again, well, sticking with CMS 122, can you further explain the upper age parameter, ages 74 and 75?
Sure. For CMS 122, the initial logic includes patients 18 to 75 with a diagnosis of diabetes and a visit during the measurement period. To determine if the patient was 75 during the measurement period, the patient needs to be 74 at the start of the measurement period. For example, if the patient is 74 on January 1st, 2022, then they will turn 75 before the end of the year. Therefore, the patient would be 75 during the measurement period. If the patient was already 75 at the start of the measurement period, then the patient would turn 76 during the measurement period, which is beyond the age of the initial population criteria.
Great, thanks. For the next question, could we scroll back to slide 16 quickly? Thank you. Okay, so on slide 16, for CMS 165 version 10, controlling high blood pressure, does the patient need to be 18 to 85 or 18 to 84 years old to meet the initial population?
Thanks, Mike. Similar to CMS 122, the initial population includes patients 18 to 85. To capture patients who are 85 during the measurement period, the patient must be 84 at the start of the measurement period. If the patient is 85 on January 1st, 2022, the patient will turn 86 during the measurement period, and therefore this patient should not be included in the initial population. However, if the patient turned 84 on January 1st, 2022, the patient would be 85 during the measurement period and would qualify for the initial population.
Great, thanks, Claudia. Again, sticking with CMS 165 version 10, in instances where there are multiple blood pressure readings and the lowest systolic and the lowest diastolic readings are used, can the systolic and diastolic readings come from two different blood pressure measurements?
When there are multiple blood pressure readings on the same day, the lowest systolic and the lowest diastolic readings can come from two different blood pressure readings from that day. For example, if the patient has two readings on January 1st, 2022, 130/70 at 7 a.m. and 120/88 at 8 p.m., the 120/70 will be evaluated, i.e. the lowest systolic and diastolic reading. Are there any
Oh,
other questions?
I apologize. I have one more.
Okay.
For CMS 130 version 10 colorectal cancer screening, why isn't there an exclusion for patients that refuse a colorectal screening? Will the measure be updated in the future to include an exclusion?
Thanks, Mike, for that question. This measure does not include patients declining the colorectal screening because the measure includes several different screening methods that count towards this measure. Not allowing patient declinations in the measure may encourage providers to discuss with patients the benefits and risk of each method to facilitate their uptake and adherence to screening, as recommended by the USPSTF guidelines. It is also anticipated that the impact of patient declinations on performance is relatively low and equal across providers. In other words, it does not result in a bias or variation when comparing results from different providers. And we do not expect that and for this reason, we do not expect that future versions of this measure will include patient refusals or declinations of colorectal screening.
Okay, great, thank you. All right, so seeing how we have just a few minutes left, looks like we don't have any other questions. I'd like to just put in a plug for, so if we could just go to slide 43 real quick. So inquiries about eligible clinician eCQM specifications are managed in the eCQM issue tracker. Include a link here. Again, new users must create an account. And then when creating tickets, again, ensure to include eCQMs as your issue type. Now, questions about eCQM resources, locating, downloading, comparing eCQM specifications, please visit the eCQI Resource Center. It serves as your one-stop shop for the most current resources to support eCQMs. And you have the contact link here. And then finally, links to all 3 webinar recordings will be posted to the eCQI Resource Center, and at that time, an announcement will be disseminated to all attendees. And of course, all webinars are posted on the eCQI Resource Center. Thank you for attending all, and have a great rest of your day.